That was a superb video, an excellent presentation. So many thanks will be passed on to Mike for that. And apologies if for the slides weren't as clear as they could be. There is a video optimization function that we put in to make the flying video more effective. But of course, what happened unaware to us is that it also made the slides a bit unclear. And I think what we'll probably do is to send out those slides with the clarity that was intended when the webinar can be downloaded in future, because it has been recorded. Okay, so let's just unpick that a bit. And before we go on to the questions and answers, so I encourage you to jot down any questions in the chat box. They may not all be answered today. I will try and answer some if I can from an aviation perspective, but otherwise we will try and make sure that Mike or other members of the panel answer them in due course. But a few points from me. One of the key phrases underlying complacency that Mike uses is the erosion of safety margin. And I think this is relevant in relation to LASA incidents and the vital importance of reporting near misses, which of course is linked to admitting the error in the first place, and that will only be encouraged by a just culture. What I also liked was that in probably one of the most sensory-rich, complex, dynamic, and consequential activities, the processes for improving performance are actually quite simple and can be adapted in community pharmacy environment, such as prioritization, compartmentalizing, debriefing, admitting errors, learning lessons, reporting, and just culture again. The only distinction I can see is that in community pharmacy, we have to make trade-offs between in areas such as commercial performance, patient behavior, staff security, recruitment, and this has an impact in our ability to achieve perfection that the red arrows might strive for. And lastly, in the role of Red 10, which was Mike's second tour as a supervisor, we could relate that to pharmacists' role of stepping back and overseeing things as perhaps a mentor and a clinical leader. So I'm just going to ask Jackie if there have been any questions that have been posted on the Q&A. So over to you, Jackie.
Thank you, Carey. I think we heard Mike talk about the pilots have to call out their own errors. And I just wondered if you could maybe talk a little bit about the barriers to people calling out their own errors.
Yes, I think probably the key barrier, which I presume resonates with pretty much everyone, is that if you're going to call out your own error, that means that there is a high risk that you'll be blamed. Whereas if you don't call it out, then there's a hope that nobody will notice. So I think the fundamental underlying principle of having no blame or just cultures is that encourages people to report. The two are hand in glove. You cannot have reporting without a just culture. And if you don't have reporting, then you can't improve. So it's absolutely fundamental to the whole principle of just cultures.
Thank you, Carey. Another question, how important is the hot wash up? We heard Mike mention that in terms of aviation. In community pharmacy, sometimes perhaps we might review incidents or near misses sometime after the event, depending obviously the severity. So yeah, so how important is the hot wash up?
The hot wash up is very important. The reason for that is that people's memories are very clear. But what is important in the hot wash up is that you don't go into detail. So it's an opportunity to flag up the issues. And if you can see some quick wins In other words, things that you can easily identify as what went wrong and can be addressed there and then you can do that. But it also prevents people from dwelling on things and perhaps just becoming self-conscious of what went wrong, and therefore then getting into the, I suppose, the risky area of not admitting a mistake that they may have made. So it's quite useful so that people can remember quickly, but also it's important that it doesn't go on very long, so that you don't actually then get into the detail and that sort of extent of the debrief.
Excellent. And have we got time for another couple of questions, Carey?
Yes, definitely. Yeah.
Excellent. I have one in here, which is very interesting, talking about working with surgeons. And sometimes I think that the question, or the questioner says that professionals don't think they should work with checklists and debriefs as they don't believe they are safer. And what are your thoughts on that behavioural issue?
This one I have come across in the past, and when I've spoken about it to aviation colleagues, they are quite taken aback. And the reason for that is that in the aviation industry, almost since the Second World War, where there was a recognition that without checklists, then people would have accidents and they would crash. And that's because there is so much going on cognitively in the workplace that it is very easy to miss things. So it has been perplexing as to why there isn't a belief that the checklists are not as safe. I think relying on memory is always risky, but then of course a checklist could be at fault as well, because you can miss an item on the checklist. So I think it's important to have that belt and braces. And what we mean by that is to actually use your memory to go through the items you need to I suppose, prepare for, but also to make sure that you use the checklist as a double check that you haven't forgotten anything. And I think the attitude probably stems from a lack of awareness as to what the risks and the dangers are of not using them.
Excellent, thank you. We've got another couple of questions in, so I'll keep going until you tell me to stop. Not sure whether you can answer this, Carey, but one of our questions is asked, what plans or thoughts do we have to help support our pharmacy teams with compartmentalising? So that may be something we want to pick up later, or you may want to have a talk about the general sort of behavioural side of that.
Yeah, I think it's all about training, and I think there is, one can have training in things like prioritisation and compartmentalising. And I think that's something that perhaps PSG can pick up and perhaps do a bit of research as to the best way to transfer that to practitioners.
Excellent. Oh, they're coming in fast and furious now. Another question is, Red Arrow is clearly very structured, operating at a military level. How do we transfer the way they work in aviation terms to pharmacy terms, particularly, the example given is a small independent pharmacy where they've been doing the same job for 30 years. But how do you transfer those sort of behaviours over?
Yeah, it's very difficult, and I think we have to recognise that the major difference and the major constraint is, for me, all around motivation. I think people who join the Red Arrows are probably as motivated as you can possibly imagine to actually achieve excellence in their field and in their work. It's probably unrealistic to expect that in a small community pharmacy, but not impossible. And in fact, and the only reason I say that is because of turnover of staff, the fact that people might be casual in many respects, but there's no reason why, if that is an intention, if that is a goal, the community pharmacies that it can't be achieved. But I think the other areas, as I mentioned, of actually making sure that it is a no blame culture, making sure that people do admit when they've got it wrong, to make sure that we do make sure that people aren't distracted, and the things that are going to be talked about later by Victoria and Chris Turner are things that are exactly the same. So one of the points I made a little while ago was that what I think is great is that the same processes for improvement in the red arrows can in fact be applied to community pharmacy.
Yes, I think we agree with that. And excuse the pun, but a question asking, how do pharmacists or pharmacy teams, how do you avoid going on autopilot when it comes to carrying out tasks that they do very frequently, like accuracy checking of medicines? Just how do they avoid that?
Again, that's a very good question that we in the aviation world have been wrestling with, and because we have exactly the same issue with long haul flights. Many hours are spent actually just monitoring systems that actually don't change very much. And so you are not only is the aircraft on autopilot, that often the crew tends to be on autopilot as well. And the technique, or first of all, the principle that we accept is that you will be, to a certain extent, on autopilot. So that's not something that you're going to be able to fight. It's something that you're just going to have to accept, that there will be things that you will do at a low level of attention. Because if you spent 8 hours in the pharmacy at a high level of attention, then I think you would be very stressed out very quickly. So I think one of the key things is accepting that there will be low levels of attention, but then having alerts and ramping up the attention levels when risks start being apparent. So by that I mean, and this links in exactly what Victoria will be talking about in terms of potential LASER incidents, or when you see things happening in the pharmacy which is about to be causing distraction or stress on the team, that's when you then alert yourself to the fact that you now need to ramp up your attention. So when things are going quite well, that's fine, but get into the habit of actually switching on when you recognize that you need to switch on. And we'll probably only be able to just get one more in, Jackie, if there is.
Yes, I think I've got the final one. Again, not sure if you want to answer this one, but what are the first steps that organizations can take to install a just culture?
Right. The first step is that there must be absolute commitment from the board. So I think it is pretty much hard work and pushing water uphill if you've tried to introduce a just culture at a lower level. And the reason for that is that as soon as the first case comes to the fore and you're trying to employ just culture principles on that, somebody higher up might not think that's a good idea for whatever legal or other reasons. So the argument and the legal trade-off and the risks have to be taken at board level. And so if you have genuine commitment at board level to a just culture, which means that the downsides of a just culture will need to be accepted as well. And what we mean by the downsides of just culture is that you could encourage the lazy, you could encourage the irresponsible because they feel, well, no, I'm not going to get blamed for this, so I won't care. Yes, that's possible, but the trade-off in terms of safety and the balance is that a just culture or a no blame culture is by far in the long term much safer.
Great, I think that's it for those questions, Carey.
Okay, many thanks indeed, Jackie. Many thanks to everyone else. And now I'd like to pass over to Victoria, who I'm sure you all know, who will talk about LASER issues in more detail. So, Victoria.
Thanks, Carey, and afternoon, everyone. I'm sure most of you know me, but for those of you that don't, I'm Victoria Steele, the Superintendent at Lloyds Pharmacy and the Vice Chair of the Community Pharmacy Patient Safety Group. Moving quickly onto the next slide, these slides have been taken from the Lloyds Pharmacy kind of patient safety headlines, the deck that we presented to the board. And we wanted to share widely some of the work that we did in 2020 around LASAs. So if you rewind to 2019, you'll all remember as part of PQS, there was a significant amount of LASA work done. And we realised at Lloyds Pharmacy that our leading LASA was different to everybody else's. And I wanted to delve a bit further into that. I think it's a great example of not waiting to learn from tragedy. I'm not a great fan of that, and I'm sure neither are any of you. So it was a really good opportunity to review our data and focus our efforts appropriately within the organisation. So if we just move forward a couple of slides, we learnt that amlodipine and amitriptyline were the top two drugs with our highest patient safety incidents. So nearly 50% of our LASA errors were between these two drugs. And so we highlighted that was the highest risk for us at Lloyds Pharmacy. And so I wanted to understand what we could do differently and what I needed to do to challenge the business. So many of you will know at Lloyds Pharmacy that we run a patient safety conference every year. Our patient safety programme is called Safer Care. And as part of the conference, I wanted to give our colleagues a really big challenge. So I asked them to eliminate amitriptyline, amlodipine LASA errors over the following 12 months. So at the conference, my team ran a workshop where we worked with 100 branch-based colleagues to understand the best, most appropriate actions in branch that would help us be able to achieve that goal. So out of the workshop came a number of mandatory and supplementary actions that we decided to take. None of it's rocket science, all very simple, and I'll talk you through what we did. So we had a number of mandatory actions that we wanted every colleague in every branch to perform. So very simply, our first action was moving our amitriptyline to Y in our dispensaries. And to be honest, I'm not a massive fan of moving stock. However, I did wonder if one of our problems was our layout of the dispensary. So was very comfortable that this was one of our mandatory actions. We then took mandatory action 2. We then took, we actually took this idea from our outpatient dispensing units. So we use a stamp with some of our high-risk oncology drugs where we have to know who has picked, labelled, dispensed and checked the prescription. So we took this idea and every single branch received a LASA stamp for them to use on all their amlodipine amitriptyline prescriptions. And as an aside, it became clear that a number of our super duper patient safety focused branches that take everything a step further, became really clear that they utilised it on all their LASAs, not just their amlodipine amitriptyline scripts. And then our third mandatory action was a safer care learning zone. So our teams all have a safety huddle once a month. We we always send them out a Safer Care case study to perform. However, they are allowed to use that time if they've had an incident in their branch that they want to talk about. But we, throughout the year, make a number of our briefings mandatory, and this was one of them. So all of our colleagues had to perform this action. And then we asked them to pick their favourite 2 or more supplementary actions that they were going to commit to. Now, I won't talk you through all of them in detail, but to highlight what they each were. So we had LASA stickers made to be affixed to the dispensing baskets for those that contained amlodipine or amitriptyline. We assigned baskets for the putting away of stock so that they were segregated clearly before the stock went away on the shelves. Daily checks of stock locations for amlodipine and amitriptyline, and also the use of clear bags for amlodipine and amitriptyline, not dissimilar to how we would dispense our CDs or our fridge lines, and I'm sure many of you do that as well. And then we took some further actions, so not necessarily at branch level. So we amended our near-miss logs to include whether they were included a LASA. We did a LASA review as a part of the near-miss review. LASAs became part of the compulsory week 4 Safer Care briefing. We added a question to our professional standards audit, and we also incorporated an element into our SOPs. So that was kind of over and above everything that we were doing at branch level. And all of those have been completed throughout the year. So following our conference in November 2019 and the launch of the challenge in December 2019, the team wrote a really comprehensive roadmap with a constant drumbeat for us throughout 2020 to really focus on driving these errors to 0. But as we all now know, March arrived along with COVID, and along with everybody else on this call, we spent quite a few months with our minds elsewhere. But the end of June, beginning of July last year, we relaunched our challenge. Now, I've got to, at this point, give my team a huge thank you and a mention who never let go of the plan, just tweaked the roadmap and tenaciously kept our branches going with the challenge. So importantly, what did we find? That's the most important thing out of all of this. I think at the end of 2019, my team were quite surprised with how dramatic the challenge that I'd set the organisation was. However, I was in the mind that if I gave us a crazy challenge to remove an error, that even if we got somewhere close, the amount of improvement that we would have covered would have been brilliant. So I think if we move on to the next slide, we will, and the slide after that, you'll start to see our results. So on the left-hand side, you'll see the top line is our errors from 2019. And then you can see on the bottom line, the reduction in errors throughout 2020. Unfortunately, I haven't taken the graph to December, because in December we had no amlodipine amitriptyline errors. So in my mind, we achieved exactly what I challenged the organisation to do in removing errors, removing these errors from the organisation. However, the reality is that we reduced the errors by 77%, which is unbelievable in my mind. I had no idea we would get over the 75% mark. And then something that I found really interesting as well is that we've gone through every single one of those errors through 2020, and not one of them caused harm to a patient. They're clearly not okay, but none of them caused any harm. Nothing had to go for an insurance claim, and when we worked out financially the difference between the 2 years, the difference is tens and tens of thousands of pounds. Whilst I know maybe not, we don't necessarily talk about money very often, but it's certainly, I found it a really interesting stat, following on from none of our patients came to any harm through those errors. So if we move on to the next slide, the other things that we discovered was that in 2019, we have 16 pharmacies that had 2 or more errors of this nature, and in 2020, we had none. And in total, the amlodipine and amitriptyline errors, not necessarily the mix-ups, reduced enormously with the focus on these drugs. So 53% from an amlodipine point of view and 42 from an amitriptyline point of view. And then again, really interestingly for me on the next slide, we saw a halo effect with our other top LASA errors. So we had a reduction of 35% in our other top errors, which I found fascinating. So just to round up with our work, clearly I've revisited this slide deck, which was presented, I think, first off in January, February in the organisation. So I've had some further reflections. So from a Lloyds pharmacy point of view, I'm unashamedly making 2020 year 1 of what I'm now calling the Lloyds Pharmacy Error Reduction Programme. We've had furthermore, we've kind of had a good look at our data following on from this, and focusing our attempts at reducing errors in a much more data-driven fashion. So that is, number of people affected and harm caused or possible harm caused to those patients, which has meant at Lloyds Pharmacy that we're focusing this year on transfer of medicines to patients errors, and also errors with community dosage systems. And then kind of my final roundup really is that, it was actually incredibly simple. The number of good ideas that we took from other parts of our business or processes that we've used to such good effect, the time we took to engage our colleagues and for them to let us know what would actually benefit them in branch, and that there's actually no rocket science to it all, and it's all completely repeatable across any organisation. I'm a big fan of keeping it simple, and I really reflected that in Mike's presentation when he was saying when things go wrong to go back to utter basics around aviate, navigate, communicate, and I'm really proud of this piece of work. I'm really proud of my team, and I'm really proud of the focus that our colleagues in branch performed with this, particularly bearing in mind what 2020 had in store for all of us. Carey, that's the end of my presentation.
Thanks, Victoria. That's absolutely brilliant. And frankly, the impression I get is it's the pharmacy equivalent of the Red Arrow's formation analysis. The picture that Mike showed, where you immediately thought, well, that's pretty good, but actually a little bit of adjustment here and there means that you can get even better. And I think the process is exactly, the simple processes can be completely employed in what you've done. In other words, why has it happened and how can we improve, and getting everyone involved in finding the solution. And that really is all that's to it. It's no more complicated than that. But doing that well is the challenge. And I think that's important. I've got one question for you, actually, Victoria, which is there an opportunity to work jointly with the NHS and the community pharmacy to review LASA errors and produce standardized work, for example, toolman lettering?
Yeah, I mean, we would always want to work with the NHS from a patient safety group point of view, because you have to, I think, unless you're in the group, it's hard to appreciate how much sharing we all do across the group. So to then be able to do some collaboration around some standardisation would be amazing.
Okay, brilliant. Right, let's take a break now, a comfort break. And if we can get back to start again at 3:30, that would be superb. Have a good tea break. And it is a great pleasure to introduce Chris Turner, who is a consultant in emergency medicine and has done exceptional work in bringing the subject of civility to the fore, and an absolute delight to listen to. So Chris, over to you.
Oh, thank you, Carey. Let me just share my screen, guys. In general, at this point, just share my screen and you get to see everything that's going on in my world, because I am basically slightly inept at this kind of thing. And hopefully you get a sign saying, when we permit rudeness, our patients die unnecessarily. Yeah?
Yeah.
Excellent. Okay. Well, I'm going to start. So it's a real pleasure to be here. My name is Chris Turner. I'm a consultant in emergency medicine, UHCW in Walsgrave in Coventry. We're a major trauma centre. And I've spent a long time in governance and trying to understand things going wrong. What I'm going to talk about today is how we treat each other, I'd like to start by telling you just a couple of quick stories about me, and I won't be any different to a lot of you guys. And that the first thing to say is that, I've been involved in things that have gone wrong. And two particular instances really stick in my mind. The first one was when I was a house officer. So a long time ago, almost 30 years ago, I was involved in something that went horribly wrong. And it became a coroner's inquest. And I deeply remember the sense of realizing that things hadn't gone well, that this was being investigated, and the extreme sense of loneliness that I had, that people weren't talking to me about it. I felt like I'd been part of this team and then the team had just disappeared. I had no idea what everybody else was doing. And I was a bit lost. I was very junior, didn't really know what was going on. And it was a scary and unpleasant place. The reality of the work that I do is that we make mistakes. And in emergency care, everybody makes mistakes sometimes. And that means that every so often they're going to occur in my career. I had another mistake, and I had many in between, but I had another mistake that happened maybe 6 or 7 years ago. And it was in a cardiac arrest, and I missed a piece of information. Now, it probably wouldn't have made any difference to the outcome, but I did miss it. And it was my responsibility and my responsibility alone. And this time, the response was completely different. This time, people were aware of my distress and they came to me. They came, they saw me, they phoned me, they checked in on me. When they saw me on a shift, they came and had a chat. And this time, I felt supported, I felt listened to, and I felt able to continue. And I suppose that's part of what led me to starting Civility Saves Lives. And Civility Saves Lives is a grassroots organisation dedicated to raising awareness of the impact of behaviour on performance. And one of the things that comes out of this is lots of opportunities for me to talk. And I've done a couple of TED Talks, I've done things like that. I've been to the Houses of Parliament, I've spoken there. And about 2 years ago, I got invited to join the NHS Health and Wellbeing Steering Group. And I turned it down a couple of times because health and well-being is not quite where I'm at. I'm actually really into the granular part of the relationship that we have with each other at work. And I was aware that this organization, we're looking at some fairly high level stuff. So I turned it down a couple of times, but then COVID came along and they wrote to me again. And suddenly I wasn't going on trips all around the country to do talks. And this meeting was online and I could do it. So I said I would do it. Immediately I got into it. I had this terrible sense of imposter syndrome because the people that are on it were all, fully half of them have post-nominals like MBE or OBE, and there are dames and sirs on this committee. And, you know, I basically sat there silent for the first couple of meetings, wondering if there was another Chris Turner, somebody somewhere in Britain who was weeping into his or her cornflakes every morning because this had been their life's work and they hadn't been invited to be part of it. But I had to go and learn about it and understand. And I think I know why they invited me to be there, but I'm still slightly unsure sometimes. But I joined the committee and they very much look like this. They are the great and the good, and people with deep knowledge about well-being. And over the course of time that I have been on this committee, and I still am, I've learned a few things. And the things that I've learned is that from their perspective, and this committee is made up of people, only some of whom are within the NHS. A lot of the other people are from external to the NHS, and people from the RAND Corporation, people from like the chief medical officer of BP, that kind of person. And what have I learned? Well, I've learned that the way that they see teams and the way that they see organizations is that they see the chief exec as determining culture. And they see the chief exec as the most important person. And in some respects, possibly the exec team as being the only really important people around determining culture. And I think they've got that wrong a wee bit. They are into big levers. This level of committee is into literally talking about legislation to change how we do things. And that's utterly not my world. And the other thing I learned about them was that they like a toolbox. So that we developed something called the Civility and Respect Toolkit, which is something you can download from NHS Improvement. And that's something that a lot of high-level organizations are into. They like to give you the 20 things you can do to make this better. And the NHS produces approximately 1 million pieces of SOP and toolkits and all this kind of stuff a year. So I think most of it just disappears. And I'm left with this sense that well-being is an absolutely massive topic. So I had to make some kind of sense of it for myself. And this is my perspective on the well-being world. That it splits for me into 3 distinct groups. The first one is resilience, our personal mastery. What can we do for ourselves so that we can cope with the workplace? Second bit is, what's the environment that we're working in like? What can people do to make that environment better? And the third bit is, what can we do for each other? Now, the first bit, resilience. Resilience is interesting because we all want to be more resilient. Our organizations love a bit of resilience training. They love it. They love giving us an app. So, you get Headspace or Sleepio, and it feels to the organization like they've helped us to be as resilient as we can be. The problem with it is that when we are working in ever more difficult circumstances with an ever increasing workload, it can leave us feeling like we are personally responsible for a system that is strained, creaking, or even broken. And whilst we all want to be as resilient as we can be, perhaps taking the burden of that on our own shoulders isn't fair on ourselves. Because I'd suggest to you that those of us who are working within healthcare, that's all of us, who are there trying to help people who are unwell and not the best versions of themselves, that we expose ourselves on a daily basis to other people being unwell, sometimes being distressed. And then we finish our day of work, we go to bed, we get up, and we do it again. And we do it again, and we do it again, and we do it again. And I would put it to you that that means that if there was an Olympics of resilience, that people who work in healthcare, those of us who are helping to get people better, that we're already Olympiad at resilience. In fact, I would put it to you that if there was an Olympics of resilience, that we would be on the podium, because we're already massively resilient. It's not natural for human beings to face up to other people who are unwell, who are in distress on a daily basis, and then be able to go back and do it the next day and the next day and the next day. And what this means is that if we're already really quite resilient, the return on investment of things like an app to help us sleep isn't necessarily massive. That's not to say that we shouldn't try to be as resilient as we can be. Of course we should. It's just that the return on investment isn't necessarily that great. Second bit is environment. And environment is really interesting because organizations quite like this bit as well. They like it because the chief exec can get the picture taken, snipping the red ribbon into the new coffee room. It's undoubtedly good for staff to have a good environment. It's good for organizations. They can improve their reputation by showing that they care about these things. But for an awful lot of us, there really isn't the space to make our environment much better. And we all try, and everybody tries to make it better. But it's a kind of finite resource. And then there's the final one, systems, or what we do for each other, which is also, in some respects, how we treat each other around here, how we do things around here, which many people would refer to as the culture of the workplace that we work in. And just as an aside, who owns the culture in your work? Who determines what your culture is like? Is it the chief exec? Or is it the people in your team? I asked this question this morning when I was talking to a couple of hundred people who work in veterinary surgeries. And they were quite clear. It was a 90%, 10% split, that the culture in their workplace was owned by the people who work in the workplace, not by the board, not by the chief exec. That's not to say the chief exec and the board don't have a role, but there was a sense that we own the culture. And instead of culture being this mountain with the chief exec at the top, the culture probably looks more like a mountain range with lots of little independent peaks. And those are the teams that we work in who have their own little microcultures. And it's not the chief exec who determines those, it's us. It's how we are to each other, how we choose to be to each other. And within all the stuff that I was doing around understanding health and well-being at work, I came across some research about engagement, and engagement at work and well-being, kind of similar things. And it was about who the most important person determining your engagement, and pretty much therefore your well-being at work is. And it goes like this. The most important person in your day or my day is our immediate line manager. When they're having a good day, we are likely to have a good day. When they're not having a good day, we are far less likely to have a good day. I'd go as far as to say, if your boss is having a bad day and you have lots of exposure to them, you are extremely unlikely to have a good day yourself. And the most important person in your direct line manager's day is their boss and your boss's boss and so on and so forth, up until we get to the big cheese, chief exec. The person who's not the most important person in your day is your boss's boss. And nor is it the chief exec. And for the people who report to you, the most important person in the day is not your direct line manager. Now, this is quite frustrating because this means that somebody else is determining our day. But it also provides us with an opportunity because actually, if you think about it, who's the most important person to our direct reports day, in our direct reports days? That's us. How we choose to treat the person that reports to us or the people that report to us is the single biggest determinant of whether or not they're going to have a good day at work, whether or not they're going to feel valued, whether or not they're going to feel heard. And I think that's a tremendous opportunity for us. Because we might be hacked off because the boss is in a bad mood. But if we can remember that the people that are coming to us aren't interested in our boss. They're interested in us and how we treat them. And that leads me on to compassion and treating each other with compassion. Now, compassion is one of those words, it's easy to say, but it kind of trips off the tongue and you say, yeah, he or she was compassionate. And then defining it gets a wee bit more difficult. And it's worth stopping and pausing and just thinking, what does compassion mean to you? Because of course, people have done work on this. And the definition of compassion that's really getting traction now is this. It's feeling the emotions of others, so having empathy. But that's not enough. It's not enough to look at somebody and go, they look really distressed, that's terrible. What makes it compassion is doing something about it. So somebody else is distressed, we recognize it, we go to them and we say, are you okay? And that's compassion. And kindness isn't necessarily compassion, although it's clearly a part of it. I could come and give you £5 just now, it'd be kind of me. But you maybe don't need £5. It maybe doesn't make anything better for you. It's the kindness that's driven by the empathy, the act of going and helping. And that's what the work that's done around this tends to be about. But I should ask, why bother with compassion? If it doesn't actually make a difference in terms of outcomes, is it enough that it makes people feel better? Now, I should tell you, it's enough for me. It is enough for me that we make other people feel better. I think for an awful lot of you guys, it will be enough for you that we make other people feel better. But there will be people who go, but if it doesn't help patients to get better, what's the point? Fortunately, there has been a bunch of research done on this, and it's been brought together gradually over the last few years. The first thing to talk about is pain. And this research doesn't come primarily from the world of pharmacies. It comes from within hospitals. And the reason for that is that's where it's easiest to do research on this kind of thing. But it's a lovely study that shows that if people make the effort to be compassionate towards patients when they go for surgery, when they come out of surgery, their analgesia requirement is literally halved. They need 50% less analgesics than the people who weren't given active compassion going before they went for their operation. The second group is about healing. Now, my world's major trauma, and a lot of minor trauma as well. And there is evidence that when your trauma team treats you compassionately, when you feel that they care about you, that people are 4 times healthier at 1 year. And I can give the references for all of this stuff because I know that sounds just incredible. There's also evidence from the surgical trials that people get better quicker when staff are compassionate to them. But there's one other study that I really would just like to tell you about for a second, partly because I think it's probably slightly unethical and therefore quite interesting, but also because it's about marriage and married couples. And in this study, they got married couples and they either put them into a group where they talked about lovely things about their marriage, or they got them into a group where they talked about what was wrong with their marriage. You can see why I think this is a wee bit unethical. And they got them into, and then they created, through a scientifically reproducible mechanism, they created blisters on people's arms. And then they measured the cytokines within the blister and the healing. When people had those blisters raised, when they were talking about positive stuff, their blisters healed 17% faster than the people who had the same stuff done when they were talking about the really negative stuff. And that seems astonishing, but the studies are out there. And the third group of people who are impacted by this are those people who recurrently come back to us. And I'm guessing for people who work within pharmacies where you can have walk-up patients, that there will be some people who come back time and time and time again. You never seem to be able to help them. And we have that in emergency departments, and we tend to get a bit hacked off with them. But the evidence for compassion here, and there's a number of studies on this, is that when we treat those people who come to us, who, let's be honest, hack us off sometimes, when we treat those people with compassion, with kindness, a full 1/3 of them stop coming to see us. And I think that's probably good for us, and it's probably good for them. And for whom should we have compassion? Well, it's pretty obvious that we should be having compassion for our patients, I think. But who benefits from it? Patients clearly do. There's more and more evidence that says that they benefit from it. But there is evidence on the other side as well. And that's us. Us, the givers of compassion. When we choose to be compassionate, when we choose to behave in a way that acknowledges other people's distress, and that can be a member of our team, or it can be somebody that we are interacting with on a client or patient basis. When we choose to be compassionate to them, the evidence is that this is good for us as well, and that it reduces burnout. Now, the evidence is not so strong for the positive benefit on us, but people like the John Templeton Foundation have a massive study about gratitude. Who is gratitude good for? Who is it better for? Is it better for the recipient, or is it better for the person who's showing gratitude? And we wait to see what the results of that are. But there's more and more evidence that says that when we treat others with compassion, that is good for us. So it's a self-therapy in that sense. Powerful therapy for us, and a powerful therapy for the people that we're interacting with. So for me, this is a genuinely wonderful opportunity We're starting to understand how, if we treat each other well, if we treat each other with kindness when we recognize somebody else's distress, if we walk towards their pain, it's better for them. And that's what I discovered when people walked towards me when I made those errors and didn't walk towards me the first time, to be fair. And I think that's something that's translatable for all of us into how we do our jobs, because it's not the chief exec that decides how we behave at work. It's us. We set the tone. We set our standards. And we all matter. Thank you very much, guys, for listening to that. I can share all the references with anybody who wants them.
Thank you very much, Chris. That was fabulous, and particularly the bits that I liked was the idea that you can choose how to react to a bad day, so that it's not contagious further on, and also that compassion is not just being compassionate, but is actually doing something about it. And I think for me, those are hopefully the key messages you were trying to get across, but certainly landed with me. So they were exceptional. Are you okay for a few questions?
Yes, of course.
We'll see if any are coming up. Just to get people's thoughts in order while they're doing that, I'll just throw one to you. Although you said that culture is 90% owned by the people, who is then responsible for changing it?
If you were to ask the health and wellbeing people that I work with, they think that the chief exec changes culture. And I think chief exec creates permission to have a certain sort of culture. But if it comes down to who's responsible for changing it, well, largely us, all of us who are within the workplace. There's no doubt that the further up the hierarchy you are, the more that your influence spreads about. But on a one-to-one basis, that I think that the thing about our direct reports getting their sense of well-being from us is really important. So anybody who's got a direct report, somebody who reports to them, I think there's a responsibility on all of us in that role to try and help other people to have the best day at work that it's possible for them to have. So I think that the responsibility is distributed. But the bit that I'm interested in is my personal responsibility and what I can do to make things better for other people at work, because I really can't change other people.
They can only change themselves. Absolutely, Chris. Jackie, do we have any that you've selected from the Q&A?
Yes, we do indeed. Given the massive impact that you say compassion has on patients, is that something you can teach? Can you teach, and how do you teach compassion and empathy?
Yes, you can. The lovely thing about compassion is it's part of emotional intelligence. Emotional intelligence, we've got a bunch of different intelligences like IQ and political intelligence, but emotional intelligence is the one intelligence that has been shown to grow throughout our lives as we get older, into our 70s and 80s. As long as we are still cognizant, as long as we don't have a dementia, we tend to become a little bit more emotionally intelligent, attuned to the people around us. So as we're becoming more emotionally intelligent, we have the chance to then exercise compassion and empathy in a better way. Can you teach people to do it? Yes, you can. If you have a look online, there are a number of people who have things like empathy toolkits. And okay, so this next bit's slightly uncomfortable. You can also fake it till you make it. You can know the words to say, and we teach some people to do this within medicine. You can know the words to say that make you sound compassionate, even if you're not the most empathic of people, even if you're maybe you don't get it so much. You can still say the words that make the other person feel valued, feel seen, and feel important. And that's enough for patients. I mean, it's better if we feel it ourselves, but there's a responsibility there as well to do this to help people if it does indeed help. And the evidence is more and more that it does.
Excellent. There is another one sort of linked to that theme, actually. Have you got any tips and guidance on how to instill a compassionate culture into an organisation, which I think you've sort of touched on there?
I think this is about role modelling it and making it normal, so that when we see a colleague who's in distress, we walk towards them and whatever fire they're consumed by. We don't walk away. We accept that they may not want our help, but the act of going and offering it at least gives them a sense that other people are recognizing what's going on. And for me, this is primarily role modeling, and then supporting other people who choose to do it as well, and not allowing the act to be ridiculed. I don't expect that would happen in many workplaces, but it's about role modeling and supporting, and we can all do that.
Thank you. I'll carry on, Carey, until you tell me we're out of time.
Please do. Please do, Jackie.
So we have a question about resilience, which again you mentioned early on in the presentation. And the questioner asks, how can you stop the blame that people feel because they're not resilient enough? Often they say that resilience is something that we need to build. Going back to the how do you stop the blame you feel yourself for not being resilient? I think that's probably come up quite a lot during, obviously, the pandemic. You've probably come across that quite a bit.
And it's a real issue. So many of us are perfectionists with ourselves. We want to be the absolute best. We want to be in control of ourselves. We want to believe that no matter what crap is chucked at us in life, we will be resilient and be able to cope with it. And it's simply not true. We can't expect ourselves to cope when we have an overwhelming burden. It's not fair on ourselves, and it's not fair to expect other people to be able to cope with that. There is a level of toxic resilience, and toxic resilience is what those people who keep coming to work day after day after day have when they have burnt out and they no longer care. They come, they kind of ghost through the day, they get their work done and they go home. That toxic resilience, it's not good for them. It's not good for the people who are around them. Compassion is perhaps part of the antidote to it, but so is a manageable workload. So is understanding that there's nobody who can't cope with it all. I think one of the things that the doctors have, so I'm speaking from very personal experience here, is this belief we should be able to sort of do it all, take it all on. I think lots of other people have that sense as well. And, the first couple of times when I burnt out, and most doctors have burnt out a number of times, the first couple of times when I burnt out, I had no idea what was going on. I just kind of felt myself turning down and switching off. And it took a while to recognize that, we have limitations to our capacity, and we're just human beings. We're all just human beings, and there's a limitation to what we can do. So expecting too much from ourselves it's not fair on ourselves. And it kind of leads into compassion-based therapies, compassion-focused therapy, that's sort of Paul Gilbert stuff, the stuff that comes out of Derby, is really powerful. He's got some lovely books about how we might be kind to ourselves, because that's part of this. It's really important to be kind to ourselves and not to beat ourselves up when we cannot cope with an intolerable burden, because that's part of the human condition. You can overload us.
Well, it sounds like we need to start reading that book. I think many of the healthcare professionals who are joining us today. Another question, if I may, when things go wrong in healthcare, if it's an issue that's a culture-based issue, based on what you've said, is that something that needs to change, the culture?
Sorry, Jackie, I missed the very beginning of the question.
Sorry. When things go wrong in healthcare, if it's something that's involving a culture-based issue, based on what you said, are you saying that obviously the culture needs to change?
So I'm guessing that this means things like when we permit people to make misogynist jokes, perhaps racist jokes, people who are unpleasant in the workplace. It's a massive, massive question. It's also a brilliant question. Because we work with people, and sometimes those people say and do things that we might find offensive.
I think I've lost.
The reason that it's a disaster for us. Sorry, did I disappear there?
Yeah, you're back. You
Oh,
just come back.
all right. So basically, when we believe that other people are bad, if we allow ourselves to believe that they're bad, that's a disaster for us psychologically. Because if we decide that they're a bad person, that gives us permission to punish them. And then we treat them in a poor way in turn. If we can get our heads into a different space that says that they're probably not bad, we're probably misunderstanding what's going on, and misunderstanding is a whole other world. If there's a chance that we're misunderstanding, if we can let them know that whatever they're saying or doing is causing distress, then the chances are that they will change their behavior. And there is a massive piece of work on this by a guy called Jerry Hickson from Vanderbilt. And his work was with doctors, only with doctors. 37,000 times they had an intervention with doctors saying, listen, what you're doing there is causing other people distress. That's not okay. And after a single intervention, when they let people know how they were landing, only 2,000 people went on to repeat offend. Those 2,000 people got a second intervention, which again was, listen, it's really not okay. This is how people are feeling about working with you. And they were down to 267. And those interventions were based in compassion. They were based on not making an assumption that the other person was deliberately trying to be unpleasant. And the end result was that the person who was hearing the message could choose to change. It's very different if you point your finger at somebody and go, you're a bad person. We don't like working with you. You're not nice. If they were to hear that people were uncomfortable with some stuff, but not that they were a bad person, not that they were not nice, then they're able to take that on board in a less personalized way and do something about it.
Excellent. And I think, well, firstly, there are a number of people who say thank you very much for the presentation, which I'm sure we'll do officially anyway.
Very kind.
But not a question, more a comment about someone would really appreciate the references that's being shared. Again, I think
Yeah, of
we
course.
mentioned that a little earlier. And I think I'm done on the questions unless any of the panelists have any questions they want to pose.
The references, by the way, come from this book,
Okay.
Compassionomics, which is not an easy read. I've got to tell you that in advance. Hopefully at some point somebody will do a brief YouTube video of this is all the main points. That's kind of how I like to take these things in sometimes. But it is chock full of references around this stuff. But I can give all the references for the stuff I've talked about today happily.
Fantastic. Thank you very much.
Okay, brilliant. Thank you very much, Jackie. And also thank you, Chris. That was inspiring as one of the comments that has come onto the chat as well, which, and I think we would all agree with that. I just want to pick out a specific link to pharmacy on the topic you've been talking about, and the Lhasa incidents, which Victoria was relating to as well. We know that we can only concentrate on one thing at a time. So in a pharmacy, although we can do several things at once, commonly called multitasking, we can only concentrate on one. And therefore, things like distractions, in particular, those things that make us self-conscious, such as ruminating over small errors, and of course, relationships, due to incivility and things associated with that, I think are especially damaging. And so it's been nice that what you've talked about in terms of incivility, and talked about the culture, talked about you know, the fact that the behavior towards people and choosing how you treat people who directly report to you, and of course your colleagues around you, and actually in fact the people you report to, because they themselves might require compassion, is very much fundamental to the sort of nuts and bolts of people making error, and in particular things like Lassa incidents. So many thanks, Chris. That's been brilliant. And now I'd like to introduce Elaine, who is Patient Safety and Professional Standards Manager for WELL, and who will share the work the PSG have been doing on health and well-being. So over to you, Elaine.
Hi, good afternoon, everybody. And I'd also like to say thank you to Chris. That was an absolutely fantastic and thought-provoking session. And I'm sure many of us will recognise things that have happened in our workplaces and maybe we'll be able to change going forward. So can I have the next slide, please? I think for all of us, we need to think about, Chris is talking about how we can apply that to community pharmacy, and particularly about us as leaders and the impact that we can have on our direct teams. I think it was really clear from Chris's talk there about the impact that we have. And I'd like to start that thinking today and talk about some of the practical steps that the safety group we've got that we can support colleagues and their well-being, which in turn will improve patient safety culture in our pharmacies. And then a bit later, I'm just going to briefly touch on the culture of sharing and learning and some work that the safety group are going to be doing shortly to understand attitudes to reporting. So we talked about well-being earlier, and the Oxford English Dictionary definition of well-being is the state of being comfortable, healthy or happy. And I think that's something all of us would want. And Chris gave us some ideas there about what we can do to support our colleagues' well-being. And what really hit home to me was, I think we've all shared there, was the talk about compassion. And if the well-being of our colleagues isn't great, then the impact on patient safety is clear. So it's imperative that we all understand the role that we have to play. Next slide, please. I hate to use the C word, the COVID word. And if any of you heard Chris talk before, he does talk about how people's instability affect their bandwidth and their inability or ability to do their role. And as pharmacy has always been really difficult, community pharmacy, lots of competing pressures, and the pandemic's only amplified those pressures that were already there and inherent in the system and in the places where pharmacists and their pharmacy teams work. So as I said, Chris talks about bandwidth. So that can be us and the impact that we have on our direct teams, but that can also be our customers and patients and the impact that they can have on us. And you'll have all seen the report in the Chemist and Druggist about the increase of abuse since the COVID-19 outbreak. And if you actually brood on those impacts, if you can't compartmentalise them, they will actually impact your day, and they can have an impact on patient safety because you don't have your bandwidth fully there, and actually you can be distracted. It was really interesting to hear Mike talk about I cannot say this word, compartmentalisation, and it is really a skill that we all need to develop. There is some support from the RPS and wellbeing. Their surveys also highlighted the mental health difficulties that pharmacists face every day. And I said, I do think that's exacerbated by the levels of abuse that we may have seen in our pharmacies. So we're interested as a group to know, what are your experiences? We're just going to run a really short poll for you. It's only one question. All the answers are anonymous. We'd just like your response to the question around, should just be coming up on your screen now. Have you noticed a change in the customers and patients being verbally abusive over the last year? Have we got most of the responses in, Nick? So hopefully we can now publish the result. Yeah, so that's amazing, isn't it? So only 2% have seen a decrease, and 50% of people on today have seen a significant increase in the amount of abuse that teams have had. I certainly know that we've had it. That's one of the areas that my team look at, and certainly the number of reports that we've had into our team has increased as well. So I think what we do need to understand is it's not personal about us. No, that's really easy to say and really difficult to do. But we need to try not to take it personally. And it isn't just an issue about in pharmacy, but it's across much of healthcare and in retail. Sorry, next slide, please, Nick. Because we know COVID's taking its toll on people. People are feeling lots less tolerant. People are feeling more stressed. People are feeling more isolated. And you'll have seen all the reports in the news and social media around this happening. And this can then play out as unacceptable abuse towards colleagues and increases stress levels. So as I said, what's important is that we need to think about what we can control or what we influence, because we might not be able to control the behaviour of customers or patients, but we can look out for the well-being of ourselves and our colleagues, and we can look for things that we can do that will help them if they're in need of some compassion. So it's practical steps we can take, and some of them are listed on here. One of the words from Chris's session that really took home to me was that toxic resilience, about I can do this, I have to do this, but you don't. So here are all some things that you can do. I think everyone's worked longer hours through COVID. For those people who are working from home, the office days got a lot longer. It's about understanding when to take a break and use your holiday. It's not a weakness to say, I need some time off. Interesting that Carey said, you can only do one thing at a time, and actually you can. The whole thing about women being able to multitask is actually not true, because nobody can do a lot of things well at the same time. And be honest about how you're feeling, both with others and with yourself. Next slide, please. Loads and loads of resources and tools out there. NHS resources are there in all nations for you and for your pharmacy teams to access. For your pharmacists or pharmacy students, then obviously there's a wellbeing hub from Pharmacist Support. And most of you, if you work in an organisation, should have employee assistance programmes. And if you remember the RPS, they've also got loads of resources are out there. So lots and lots of stuff to access, and it's absolutely not a weakness to do that and to recognise that in yourself. And as a group, we've pulled together some guidance which has been recently updated, just some top tips for self-managing your wellbeing, and a lot of those do reflect back on the previous slide. They're really, really simple, and if you want to see those, they're available on our website. Next slide, please. So as I said before, I hand back to Janice, I just want to touch on the culture of learning, because we are guided by the principles of sharing and learning, and that report Learn, Share, Act, Review wheel. And if you aren't reporting everything, then the actions that you take might not improve the safety in your pharmacy because you don't have the right information. If you link back to Mike's video and to Carey's comments about reporting, it's all about learning and what you can do to make things better. So we previously had run a safety culture. We're going to be rerunning that patient safety culture soon. So this is a not at all subtle plug for that patient safety culture survey. We would really, really like you to fill that in. It's open to all pharmacy team members to do it. And it really is going to be a key part for us about improving and understanding where we are, what are the barriers to reporting, what are the enablers to reporting. And I think it's also particularly interesting at the moment and pertinent because obviously decriminalisation of errors has happened since then, and the last time we ran it, and we know the NHS is expecting to see more reporting. So we really want to understand what's reporting and what the barriers are out there. So please, please, will you fill that in for us? And thank you for listening. And I'm going to hand over to Janice.
Thanks, Thanks, Elaine. So, wow, what really great sessions. They've all been linked together, but also very diverse. So hopefully there's been something for everybody within the content there today. It's certainly given me plenty of food for thought. There's a couple of golden threads, I think, running through all of the sessions. And I think our speakers have highlighted the importance of a high-performing team, learning from when things go wrong, certainly having a laser-like focus on quality and continual improvement and understanding why things go wrong, not just that they have gone wrong, but understanding the why, I think is crucial. But also having a supportive culture that shows compassion. And we've seen some really clear links between what happens in the aviation world and also what happens in pharmacy. I think it's brought home to me how much more important the report, learn, share, act, review wheel is, and the bit in the middle about being open and honest, because that links in with the culture, whether that be a compassionate culture or a just culture looking at errors. And there's a lot of analogies to how you can take these things forward in pharmacy. So if you really want to understand why things go wrong, we have to encourage people to do root cause analysis or fishbone, to spend that little bit of time really thinking about it. You know, reporting on its own is not just enough. And many of you will already be continuing to do the patient safety reports that we all complete monthly, which was started as part of PQS, and undertaking the safety huddles. And it's those kind of activities that actually embed some of these principles into what we do on a daily basis. So we heard from Mike about complacency and shortcuts and trying to be efficient and how that can impact safety. And I think we're all in that place. We've all had to work differently during COVID, and a lot of the things that have changed have been really good. But in a lot of cases, the pressure that everybody's been under has led to some shortcuts, and not all shortcuts are good shortcuts. Sometimes they're improvements, but sometimes they're not. And I think if we can actually get to a stage where everybody is happy to call out their own mistakes, and that analogy to near misses is really powerful. What you want in any pharmacy is obviously a higher level of near misses and a lower level of actual incidents, and that healthy near miss reporting is a good sign of a patient safety culture. So open and honest reporting is crucial, and it's our responsibility. It's quite clear from everything that everybody has said that it's our responsibility to create this culture, and so that we can get great reporting and we can learn from it and improve, because we do want to make a difference, and we all have that opportunity to impact on this. So the culture is down to all of us, whether that be in the groups that we attend, whether that be in our own teams, whether that be in our wider teams or in the whole organisation. We can all play our part. And Victoria highlighted how important it was to use the data that gets pulled to actually drive these safety improvements. And actually she was able to show what actually having a clear focus on a challenge and harnessing the power of everybody in their wider team has had in actually solving a problem in a simple and systematic way. And that kind of learning can be applied to all sorts of challenges that we face in community pharmacy. You know, we all want to keep patients safe, and often we're putting patients before ourselves, but it's quite clear from the comments that Chris has made and that everybody else has shared that we can keep patients safer, longer and better if we look after ourselves as well. So we have to look at things in the round. We want to be having our best day, and that diagram that Chris showed about the impact of line managers, we are all line managers ourselves. We're all part of these wider teams, and these different activities that we're all getting involved in can make the difference between somebody being at the top of their game or not at the top of the game. And if we want to encourage people to work differently, then we do need to look at perhaps some of the workload, the burdens, and the things that are getting in the way of everybody being the best that they can be. I think it was really powerful when Chris said that we shouldn't expect people to just continue to cope. Resilience, whilst it's something that we have all developed, doesn't have to be a badge that we wear with pride and just go, oh, we're getting more resilient and more resilient. That's not necessarily helpful, and toxic resilience is clearly not good. We all do have limited capacity, and there is a challenge that we do expect sometimes too much of ourselves, of our team. So it's all about getting the right balance. So hopefully everything we've heard today is about creating this patient safety culture and understanding what contributes to that. It's It's quite clear that process alone and having more SOPs, you know, is not really going to change things. So you do need a high performance team, you need trust, you need care, you need compassion. And it's quite clear that little things will make a massive difference to patient safety, but also to the health and well-being of our colleagues. Kindness absolutely does matter, and we shouldn't underestimate the power of the right word, a kind word here or gesture there, to our teams or to our patients, and the long-term impact that can have. It might seem very little to us, but actually it has a huge impact on them. And we can all take ownership of this kind of behaviour and lead by example, because we all know that pharmacy teams copy what we all do. So if we all start doing this, then actually that'll spread, and a few small actions will start to be everybody doing those actions, and it'll just become how we are in community pharmacy. So we're having that kind of knock-on effect. It's a bit like dominoes, isn't it? So our environment is going to constantly keep changing. There's no evidence that the things are going to settle down. And I think we can change the culture and bring out the best in everybody. And some of this change is also bringing out the worst in people. But by thinking about some of the activities and the information that have been talked about today, we can perhaps recognise when it's bringing out the worst in people. Chris talked about, you know, that perhaps sometimes we do treat people differently, that maybe we are labelling people as bad people in inverted commas, but perhaps if we just take that time to understand, then actually we can change things a bit. So let's think about our part in changing this, and we're crucial to it. And by doing that, it will maintain and improve patient safety. So overall, I hope the conference has shown that we've all got this opportunity to make a difference. I hope that you're going to take some of this learning and build it into your professional practice, so that we can all continue to share, learn and improve overall what we do. A further plea for our patient safety culture survey when it's launched. The more people who fill it in, the better the data we'll get, and the more accurate insight we'll get into what is actually happening out there. And we want everybody at all levels, you know, throughout the team. This is a team activity, because it's the team that actually make a difference to patient safety. It's not a pharmacist-led activity. So please do encourage people to participate. A reminder, you can watch all of this again when the link is posted on the website, and certainly given the issue we had with the slides, Mike's slides, I think it would be good for you to watch it again. I've watched it several times now anyway, and you do get something different each time you actually see it. So it is the kind of thing that does actually bring something different. So please do take the time to do that, and please tell other people who weren't able to be here today about the conference, and hopefully they have an opportunity to watch it as well. This is a great CPD opportunity, because actually linking some of these things together does link into a lot of the areas that we should be focusing on, obviously within our GPHC standards. Just finally, I want to thank all our speakers. It's been absolutely fabulous. I'd like to thank Carey as our facilitator, but also all the community pharmacy MSOs who have been supporting behind the scenes, and also in particular Emily, who's helped pull the conference together, and she's been supported by some of her colleagues at CCA today to make sure that this all runs smoothly. It's no mean undertaking to try and do something like this, particularly virtually. We all said we'd have preferred to do it face to face, but that just wasn't possible. But as you can see, there's lots of things that can potentially be hiccups. So it has truly been a really team effort to get us to this point. And finally, I just want to thank again our sponsor, Accord, who I don't think we could have made this happen without their support. So a big thank you to them. And hopefully you'll fill in not only the culture survey, but also the evaluation form that Emily will be sending to you, because we clearly want to learn from feedback and improve what we do. It's some time since we've done a conference, and hopefully this will be the start of future ones to come. We can certainly learn from what happened today. We'll be having our hot debrief shortly, so we can understand what we can do differently when we have videos embedded in PowerPoint and some of the other things, so that next time we do this, we can be better and improve and give all of you the best possible conference that's going. So thank you all for coming. Please do take the time to watch it again, and thanks for your ongoing support.